if you see a child who is starting to pronounce some words, first thing is vocalization. He or she will start saying ah, ba, baba, papa. After that, he will start actual phonation. It's a complex thing, okay? Lots of things, neuromodulation in your brain, everything happens, okay? To have a good phonation, to have, conversational phonation, you have to have a good hearing as well, right? So, when you have a good hearing, the child will listen to your voice and his brain will there will be neuro remodulation and all, and after that he will start phonating, right? So with time in your life, this voice box, it's a new evolutionary, if you think that, it's a new thing, phonation. Every species in the world has little bit of vocalization, and to articulate meaningful sentences and words, considering your culture, your language, your way of talking, everything, it came evolutionary later period. We are higher mammals. So after that, we will start phonating. So in this voice box, there can be some anomalies, some problems that can be sometimes benign, sometimes malignant, right? Malignant laryngeal disease, that is laryngeal CA, will be discussed in another class. Today's class is regarding the benign disorders, right? So mostly this can be non-neoplastic or neoplastic. Non-neoplastic means which is not a tumor, right? Neoplastic means that is tumor but not malignant. Okay? Neoplastic can be malignant, but here today we will discuss about some neoplastic lesions which are not, cancer. Okay? So this is a classification to give you an idea what are the common things that can happen. Solid thing, focal nodule, focal polyp, Reinke's edema, contact ulcer, intubation granuloma, leukoplakia, amyloid tumor, some cystic things, saccular cyst, ductal cyst, laryngocyst. Okay. Other things, non-cancerous neoplastic tumors, it can be squamous papilloma, juvenile papilloma, adult onset papilloma, chondroma, hemangioma, granular cell tumors, glandular tumor, rhabdomyoma. That covers more or less the things happening. So, lot of things. Let's start. Vocal nodule. Okay, it's one of the most common diseases of the larynx, if not the most common. Okay. Who has these things? Singers, also known as singers nodules. Screamers, if you scream a lot, you will have this thing. Teacher's nodule, hawker's nodule, mummy's nodule, okay, it's a new terminology. অনেক পেশেন্ট আসে, হ্যাঁ, টডলার্স এর মা, ঠিক আছে, বাচ্চা সারাক্ষণ ছটপট করছে, তাকে তার পেছনে চিৎকার করতে 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 করতে, হ্যাঁ, যখন এই পেশেন্টরা আসে আমাদের কাছে, ফার্স্ট থিং উই আস্ক, ইয়াং ফিমেল, হ্যাঁ, গলায় একটা এরকম ভাঙা ভাঙা স্বর নিয়ে এসছে, ফার্স্ট থিং উই আস্ক, ডু ইউ হ্যাভ এ চাইল্ড ইন ইউর হোম? Most of the times, 99% times, answer is yes, okay, and I need to scream a lot because of him or her, okay. This is the side effect of being a mother. Fathers also have, but fathers less scream, okay. So how does this happen? See, this is the vocal cord, this is the epiglottis, okay, these are the aryepiglottic folds, okay. You need to draw this picture in your exam, okay. This is the vallicular area and base of tongue, okay. So this is the epiglottis. Epiglottis has two surfaces. One is lingual surface towards the tongue, another one is laryngeal surface, okay. If you pass your scope beyond this laryngeal surface of the epiglottis, you will find vocal cords. Which position these vocal cords are right now? Adducted or abducted? Adducted, okay. This is supposed to close totally. When it is total adduction, supposed to be closed totally, but here is a gap, right? We call it phonatory gap, right? Why this is the gap? Because see, there is some nodular elevations here. Okay, where it is situated, this is the anterior 1/3, this is the posterior 2/3 of the vocal cord. This is the typical location. Okay, if you get this picture that bilateral there is some nodular structure here at the junction of anterior 1/3 and posterior 2/3, it's most likely it's a vocal nodule, right? And why this husky voice? Vocal nodule typical voice hoy, যখন patient আসে চেম্বারে, by listening to his voice we can identify it, what is happening. Anyway, and this, there is leak of air leakage is there, so that phonatory gap gives this typical voice. Okay, so how will you treat this patient? Any idea? You have to ask the patient to have a voice rest. Okay, microphone, বাড়িতে মাইক্রোফোন নিয়ে বাচ্চাকে ইয়ে করবে, that's a good idea, obviously, that's why we are using microphone here. Okay, so that we do not need to scream it. But voice abuse is a big thing. Okay, you have to know correctly how to use your voice. Okay, ফেলুদা তো পড়েছিস নিশ্চয়, সত্যজিৎ রায় পড়েছিস সবাই? হ্যাঁ, হরবোলা কি জানিস? হরবোলা, ventriloquism, those who can produce different kind of voices, right? So that is basically a voice abuse. You know, hawkers basically tara ki kore, they speak in their home in a natural voice, and in their in trains or buses or streets they use a different kind of voice, right? That is also voice abuse. Okay, that is not your natural voice. You have to speak slowly and naturally. Okay, whichever is your natural voice, you have to use it. Don't try to scream or use another kind of voice that is giving strains on your vocal cords, right? Why this is the location why the vocal nodules happen here? Because that is the most vibrating part of the vocal cords. Okay, so what is the pathology? What is the pathology? Just read it out. Trauma to the vocal cords in the form of vocal abuse or misuse causes edema and hemorrhage in the submucosal space, right? And our body will try to heal it. There will be an inflammation, and ultimately there will be hyalination and fibrosis there. Okay, fibrosis is the final part of the inflammation healing process, right? So the epithelium will goes under hyperplasia and forms this nodule, right? So how will you treat it? First thing is you have to use your natural voice. Do not scream, right? So the common features, clinical features is definitely hoarseness or altered voice or change in voice, whatever you want to say. We in medicine we call it dysphonia, right? This means disorder of phonation. It's a broad term, like hard of hearing, like hearing loss, right? There will be vocal fatigue because of this thing. Patients will ultimately, they cannot speak for a long time, okay? Because there is strain. Anything strained, you will get tired ultimately. Okay. So there can be a little bit of pain, soreness, voice breaks at higher range, okay? অনেক সিঙ্গার্সদেরও হয়, ওকে? Patients usually come to us, and I used to sing a lot in high, we call it, what is it called? High octave, high scale. So that gives more vibration to that mucosa, and it will ultimately lead to vocal nodule, okay? So after this voice rest, the medical management or the conservative management, okay? After this voice rest and aggravating factors like acid reflux, allergies, infection, all these things, okay? After you manage, even if after that the patient is not recovering, that means you need to do something, right? So we are surgeons. What we are trained to do is cut it out, okay? But you have to train first the patient that even after I cut it out the nodule, if the predisposing factor is still there, you will again have this nodule, right? So this training is very important, okay? So what are the options? How will you do that? We will cut it out, as simple as that. We will excise the nodule. How will you do that? So highly vascular structure. In millimeter, if you damage anything, okay, there will be another dysphonia. There will be another fibrosis, there will be another scarring, and that will lead to permanent dysphonia. Okay, this is manageable up to this level. So we have to be very careful. There are different kind of techniques, tools. So we use lasers nowadays. Okay, we just cut it out the nodule. We call it microflap technique. We just elevate the flap. Okay, from the mucosa, submucosal flap is there, and we cut it out the nodule. Okay, so best tool is this carbon dioxide laser. Okay, even after that, we have to go for the speech therapy, and you will ask the patient to come every month at least, to train her, to emphasize the importance of not to do this voice abuse. Okay, okay. But sometimes see a hawker, if you say him that you cannot scream, he will not listen. That's why you have to re-emphasize it. Okay. Okay. Another thing is vocal polyp. Okay. Vocal polyp, by classification, it is greater than 3 millimeter. Okay. And it has to be in the free edge of the vocal cord. Nodules are submucosal. Okay. But polyps are free edge. That is from the mucosal level. Okay. Okay. So it is also a space occupying lesion. Because of the polyp, the vocal cords cannot close completely and patients will have hoarseness. Similar symptom. Okay. But the voice quality is different. Okay. So mostly in smokers and 30 to 50 years of age, chronic voice abuse history thakbe, they are getting this polyp. How will you treat it? The pathology I already told you, the similar thing, mostly the aggravating predisposing factors are same. Okay, but the age level is different. Okay, profession can be different, you can have it, even I can have it. Okay. Okay. So how will you treat it? How will you treat it? Again, this surgery, right? Vocal polyps, yes, definitely there is a role of medical treatment that you try to control the aggravating factors. Voice therapy, okay, some kind of NSAIDs, it should be stopped, right? So that there is less hemorrhage, less acid reflux, all these things. But the mainstay of treatment is surgery. Okay. So you have to excise the polyp, like nodule. But the technique is little bit different. Okay. See, like the functional endoscopic sinus surgery, where we try to preserve as much as mucosa possible, healthy mucosa. The same principle here also in microlaryngeal surgery. As a whole, the surgeries are known as microlaryngeal surgery. Okay. We use microscope, we use a laryngoscope, and we cut it out. Okay. So the normal mucosa you have to preserve. Okay. And a simple excision for pedunculated polyp, where you know what is pedunculated? Yeah, there is a stalk. Okay. So pedunculated polyp, simple excision is enough. But if the polyp has a broad base, then you have to elevate the flap, you have to excise it out, and you have to reposition the mucosa back. Okay. Okay. So there are different types of vocal polyps that you need not to know, but just the hemorrhagic polyp, where you can see there is a hemorrhage inside. Okay, it's a reddish appearance, bright red appearance, dilated blood vessels are there, and gelatinous polyp. Okay, gelatinous polyp is most common, followed by hemorrhagic polyp. Okay, it can be mixed as well. So the clinical features are as well as same. Okay, same thing, but the voice quality is different. Okay, this is the capillary ectasias. This is the microvascular lesion. Abnormally large and weakened vessels that are most commonly found on the superior or the medial aspect of the mid-membranous portion of the vocal cords. Same thing, okay? Basically, it's our body's attempt to heal any voice abuse, okay? So with laryngoscope, you can see there are large vessels running through this thing, okay, in the vocal cords. And for this, how will you manage this thing? What is your common sense? Management is mostly conservative, okay? The same thing, you have to manage with intake of anticoagulation medication should be stopped, acid reflux has to be controlled, voice therapy, okay, residual voice, what is this? Laryngeal microsurgery is an option where we are basically coagulating the large vessels, okay? But mostly it's not needed, mostly the medical management is enough. This is very important, Reinke's edema. What is Reinke's space? You know the vocal cord layers, okay? This famous picture, you have to know it, okay? So this is the Reinke's space here, okay? You know, this is the superficial layer of the lamina propria, okay? This is the stratified squamous epithelium, right? And this lamina propria has two layers, superficial and deep layer, okay? After that, vocal ligament and thyroid, the vocalis muscle, okay? So this space is known as Reinke's space. So in Reinke's edema, what happens? There is edema in this space. Why this happens? Mostly found in 100% of the cases, mostly found in smokers. Okay. Reinke's edema is also known as this thing, smoker's larynx, chordal polyposis, chronic edema of the vocal cord. Okay. Polypoidal degeneration of the vocal cord. See the appearance. It's like a polypoidal edges, the normal luster, normal color of the vocal cord is missing, okay, the edges are highly hypertrophied, okay. If you get this thing, sometimes it's commonly mistaken as a growth, but mostly you will find it in bilateral conditions. Bilateral vocal cords are mostly involved. CA larynx can also involve the both vocal cords, but it's not symmetrical mostly, okay. But here you will have it asymmetrical, this thing, okay. So it's chronically and irreversibly swollen. It's difficult to manage with your medications. Obviously, you will ask the patient to stop smoking and ask the patient not to abuse the voice, but many a times we need to operate it. How will you operate it? No, it's middle-aged men actually, okay. Why middle-aged? Because you have to be a chronic smoker. So you have to pass some years of your life, okay. So mostly women can also be smoker, but women get more chance of becoming a chronic this thing changes. But in our country, mostly the men are smokers. So mostly in the middle-aged men it occurs, okay. So Reinke's edema, obviously you will try to fix the thyroid issues, you will try to fix the smoking issues, try to fix the voice abuse, you try to fix the acid reflux. These are all common thing in all the vocal cords, conditions, okay. But there are gradings you need not to know, but how will you manage it? That is important, okay. First of all, you have to know whether there is any other possibilities or not, okay. If you suspect anything else like a CA or any other thing like respiratory papillomatosis, whatever, you have to take a biopsy, okay. In biopsy, you will get this thing clear that it's a clear-cut case of Reinke's edema. Then you will open it up this space, you will drain the edema, you will fix the what is it called? It's a high tension space, okay. You have to fix this tension, okay. After that, you will again reposition the mucosa, and you can shiver the edges, the hypertrophied edges, you can shiver it out as well, okay. This is the thing. This is also, jodi porikha jigesh kore, you will just say it's a kind of microlaryngeal surgery where we use many instruments like lasers, cold instruments, debrider, all these things, okay. Okay, so this is the typical incision. You will get into the Reinke space, you will drain the fluid out, you will try to fix the additional tissues and will obviously not disturb the mucosa. Okay, this mucosa is extremely vital. Okay, this is called reduction glottoplasty. Okay, next, this is a contact ulcer. It is a contact granuloma. Okay, again, smoking is a big factor, as well as acid reflux, mostly found in the posterior part of the vocal cords. Okay, it's a chronic inflammatory condition where the thin mucosa and perichondrium overlying the cartilaginous glottis becomes inflamed. Okay, কাউরির একটা হ্যাবিট থাকে, হ্যাঁ, ওই গলার মধ্যে আঙুল দিয়ে বমি করার থাকে তো, and many patients are suffering from this gastroesophageal reflux disease. তো জাস্ট এই পোস্টেরিয়র পার্টের ভোকাল কর্ডের পেছনে, দিস ইজ দ্য ইন্টারঅ্যাডেনয়েড এরিয়া, তার পেছনেই থাকে ক্রিকোফ্যারিংস, দ্যাট ইজ দ্য বিগিনিং অফ দ্য ইসোফেগাস. So that acid will come in contact with this posterior part and there will be this ulcer. It's a burn, basically it's a burn, acid burn, and this part will have this chronic inflammatory ulcerations. Okay, so এটাও মিস্টেকেন হতে পারে গ্রোথের সঙ্গে, তাই তো? সামটাইমস মনে হতে পারে এটা কোনো ক্যান্সার কিনা, হতে পারে. Again, if you are in doubt, you have to take a biopsy. Okay, so how will you treat it? Obviously the offending factor, you have to control it. Okay, you can give some antibiotics for initial period because there is inflammation, but the strict control of this acid reflux is extremely important. Yes, anyone asking anything? Okay, so your alcohol and caffeine intake has to be controlled. Okay, anything that can give more and more acid reflux you have to control. Okay, okay, how will you treat it? Mostly medical, and it's a surgery is the last resort. When the ulcer, you cannot cure an chronic inflammation with surgery, okay, until and unless you address the main offending factor. But if it is very, very disturbing and if you are in doubt, you have to go for the surgery. You just remove it out and you will take a biopsy, okay, from that area. This is intubation granulation. Our anesthesia fellows sometimes while intubating, we just injure this posterior part of the anterior part of the vocal cords are mostly responsible for your phonation. Posterior part of the vocal cords are mostly responsible for your respiration. Okay, so যখন টিউবটা যায় তখন mostly it lies on the posterior part. Okay, sometimes this tube can injure the mucosa overlying and it can give rise this intubation granuloma. It's again an inflammatory condition. Okay, most of the cases it goes away, but sometimes you need to intervene. The intervention is same. You have to go for a microlaryngeal surgery, right? Okay, so pathology is same. I told you the pathology of granuloma. Granuloma is a chronic inflammatory condition. The same thing. Okay, symptoms is obviously hoarseness, but hoarseness will not be that much. কেন? hoarseness হবে, but if you consider the size of a granuloma, অনেক বড় গ্রানুলোমা হলে অনেকটা hoarseness হবে. Okay, why? Because I told you the anterior portion of the vocal cords are mostly responsible for phonation, আর এটা mostly posterior part হয়. So basically পেশেন্টের dyspnea হতে পারে. Okay, sometimes noisy respiration ও হতে পারে, stridor like sound it can cause. Okay, so in all cases what you have to do, you have to examine the larynx with a fiber optic laryngoscope. You have to assess the condition, you have to assess the etiological factors, predisposing factor, and you have to intervene. Firstly, conservative management, then if not resolving, we will go for a surgery. Okay, okay, cysts, intracaudal cysts. Okay, intracaudal cyst কোথায় হবে, কোন জায়গাটায় হবে? মিউকোজাতে হবে, সাবমিউকোজা লেভেলে হবে? মিউকোজাতে কি করে cyst হবে? So intracaudal, that means within the cord, তাই তো? So mostly submucosal. Okay, so It can be epidermoid cyst, it can be a retention cyst. Okay? So mucous retention cyst is thought to arise from a blocked minor salivary gland. তাই তো? তাহলে minor salivary gland ওখানে থাকে কি থাকে না? থাকে। তাহলে তাদের ওপেনিং গুলো যদি কোনো কারণে ব্লকড হয়ে যায়, there can be a retention cyst, right? Okay, আর epidermoid cyst, keratin and cholesterol debris. Epidermoid cyst তো দেখেছিস নিশ্চয়, sebaceous cyst, epidermal cyst, dermoid cyst. You know that? Okay? So it's another thing, epidermoid cyst. Okay? Get this picture? This is a retention cyst. This is an epidermoid cyst. Retention cyst টা মানে ক্লিয়ারলি দেখলে বোঝা যায়, হ্যাঁ? That medially protrude থাকছে, you can clearly differentiate between the vocal cord and this mucosa, and just in between there is a cyst. An epidermoid cyst, you see it's a broad based, vocal cord এর উপরেও যেন spread out হয়ে আছে. Okay, this is basically an epidermoid cyst. How will you manage it? How will you manage it? Obviously, this will not go with medical management. You have to excise it. Okay? What is the name of the surgery? Microlaryngeal surgery. It's a big topic, big heading. So, কি করে করব আমরা? Laryngoscope নিয়ে যাব. We'll inject here with normal saline or something, lignocaine adrenaline or something. So, we will have a space. We call it hydrodissection. Then we will give a small incision like this. Okay? We'll elevate the flap. We'll take the cyst out and we'll replace back the mucosa. Okay? শুনতে যতটা ইজি, করতে ততটা কঠিন, because it's a very small structure. 1 millimeter এদিক ওদিক হলে you will have a permanent scarring. So patient hoarseness of voice নিয়ে এলো, patient hoarseness of voice নিয়ে গেল. What is the benefit? Okay? So epidermal cyst is like that. Okay? Vocal sulcus or sulcus vocalis. ঠিক আছে? Another condition. There is a theory that, it's a recent theory, that sulcus is basically a ruptured congenital cyst. Okay? So how will you find out? If you find a groove along the mucosa, if you find a groove along the mucosa, that is a sulcus vocalis, right? Okay. So what are this is basically 3 types. First is physiological, reflux, acid reflux এর সাথে, we call it pseudo sulcus vocalis. Okay, it's not a true sulcus. So acid reflux এর জন্য chronic irritation হয়ে there can be a sulcus. Okay. Second one is sulcus, what is it? Vargature. Okay, which is basically goes down to the superficial lamina propria. Okay, and third is sulcus vocalis, that is the true sulcus vocalis, where it extends into the deeper layers of the vocal ligament. Okay, it's very difficult to treat because there is actual loss of tissue. Actual loss of tissue hole, it's very difficult to treat. We have many options for that, but it's difficult to treat. Okay, this is the sulcus. See, this is the vocal cord, there is a groove, right? This is the sulcus. So type 1, type 2, type 3, কত দূর অবধি extended. Okay? Okay. So what is the symptom? Most common symptom? Hoarseness of voice. Okay. Everything is hoarseness of voice, but it varies. Okay? So যত deep হবে তত বেশি vary করবে, right? Okay. So that is the catch line. It's difficult and results are variable. Okay, and it's difficult to dissect because there is actual fibrosis there. So তুই যখনই মিউকোসাটা তুলতে যাবি at that level, it will tear, right? You do not find a space there, a plane there. So it's difficult to treat. So that we have basically developed many things. Sometimes we call a little bit of injection laryngoplasty or injection thyroplasty. This type of concept is there, where we try to inject something, some material, and try to make it as normal as possible, right? But acid reflux management is extremely important. Amyloidosis, তো নিয়ে নিশ্চয়ই অনেক পড়াশোনা হয়েছে ইন মেডিসিন। ভোকাল কর্ড, this larynx is known for amyloid tumor. Okay, it can be primary thing, it can be secondary amyloidosis as well. Okay, so amyloid deposition in a diffuse submucosal space or in the subepithelial space, it can be present. It's a very rare thing, but the treatment is you have to excise the tumor out with thorough use of CO2 laser. Okay, laser is extremely important here. Amyloid diagnosis ki kore kore, it can be asked. Congruent staining. Okay, আর কি একটা আছে bifringent microscopy. Yeah, amyloid bifringent microscopy. Okay, we are not specialists in this thing. We just take it out the tumor. Okay, and send to the pathologist. He will tell it is amyloid tumor, and after that we will take the advice of the internist people. I mean internal medicine people. এবার কি করব? Okay, mostly the answer is there is no treatment, right? But we have the treatment, we will excise it out. Okay, this is keratosis. Leukoplakia. Okay, kind of leukoplakia. Okay, leukoplakia আর erythroplakia, তাই তো? কোনটা বেশি malignant potential আছে? হ্যাঁ? কারা কারা erythroplakia ফেভারে হাত তোলো? মাত্র দুজন, আর বাকিরা সবাই leukoplakia ফেভারে। Which has more malignant potential? কোনটা বেশি ম্যালিগন্যান্সিতে কনভার্ট হওয়ার চান্সেস বেশি? লিউকোপ্লাকিয়ার ফেভারে কারা আছো? তুই বাকিরা কি নোটা? তাহলে একজন লিউকোপ্লাকিয়া, দুজন এরিথ্রোপ্লাকিয়া। ওকে, সো এরিথ্রোপ্লাকিয়া জিতে গেল ভোটে, and that is the correct answer. Okay, the erythroplakia has more malignant potential. Okay, see if you get this whitish structure, I mean whitish layer, this is basically keratosis. Okay, so if you get the definition, you just read it out. Laryngeal keratosis is a clinical term which refers to a group of epithelial lesions in which abnormality of the epithelium, changes of growth, maturation occurs, keratosis, hyperkeratosis, cellular atopia, dash blah 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 blah. Okay, so these lesions, the catch line is these lesions have potential to evolve into carcinoma in situ. Okay, what is carcinoma in situ? Yeah, where the basement membrane is not involved. Right? So how will you treat it? Excision. কি exercise করবি? You will excise this lesion, the leukoplakia. তার কতটা ডিপে যাবি? আপ টু বেসমেন্ট মেমব্রেন। কি করে বুঝবি অপারেশনের সময়? বেসমেন্ট মেমব্রেন ওরকম ভাবে বোঝা যায় নাকি? Okay, you will not injure the vocal ligament. Okay, if you injure the vocal ligament, then you are in trouble. There will be diffuse scarring. Again, patient came with hoarseness of voice, we'll go with hoarseness of voice. Okay, so we will excise it for two reasons. One, improvement of the voice. Second is malignant potential রয়েছে, so we will try to eliminate it as early as possible. Right? So তারপরে যদি ম্যালিগন্যান্সি আসে রিপোর্টে, দিস এ ম্যালিগন্যান্সি, তাহলে কি করবি? কেমোথেরাপি? নো। ভোকাল কর্ড ম্যালিগন্যান্সি, ভোকাল কর্ড, দ্যাট ইজ দ্য laryngeal malignancy তো তিনটে লেয়ারে হয়, supraglottic, glottic and this thing. This is glottic malignancy. Glottic malignancy responds well with radiotherapy. Okay, okay, but many a times only this excision or stripping is enough with serial follow-up. We have specific tests for that. We use different kind of microscopes. Okay, microscope অনেক রকম settings রয়েছে where we can get an idea relatively with the metabolic pattern or the vascularity of the underlying structures. We get an idea যে এই জায়গাটা malignant হতে পারে কি পারে না. Okay, ENT surgery is all about microscopes and endoscopes and lasers and debriders and coblators, all these things. Okay, lots of machines. So we'll get it out. Okay, so keratosis is more localized. If it is more than keratosis, then it is leukoplakia. As simple as that. Like erythema multiforme, Steven Johnson syndrome and 10. Right? according to the area of involvement, percentage of involvement, we classify it like that. Okay. Okay, again smoking is extremely important. With smoking there will be chronic cough. With chronic cough there will be vocal irritation. With vocal irritation there will be leukoplakia. Okay, smokers দের অ্যাসিড রিফ্লাক্সও বেশি হবে, তাই তো? আর যারা অ্যালকোহলিক হয় তারা একটু বাইরে বেরিয়ে একটু বিড়ি সিগারেট খেতে পছন্দ করে, তাই তো? So these two habits, you must not have these habits. Okay, no smoking, no drinking. Okay, so with lasers, what is the advantage of lasers? Lasers will get you more accurate dissection. Lasers will get you less bleeding, less damage. Okay, barbar kore bolchi, vocal cord is extremely intricate area. Just with the vibration of some sub-millimeter, millimeter level, you will get this voice. তাই তো, যেটা আমরা অরিজিৎ সিং এর গলায় শুনছি। So অরিজিৎ সিং is because of this vocal cord, and this vocal cord is so delicate, so fragile, so tender. You have to take care of it, otherwise you will lose your voice. Imagine a life without your voice, how will it be? তাই না? It's a special sense, right? Saccular disorder. Okay, laryngeal ventricle নিশ্চয়ই anatomy পড়াতে হবে না এখন? There is something called, some area called laryngeal ventricle, তাই তো? So ventricle there can be some outpouching, okay, because of some natural defect or natural weakness, তাই তো? That outpouching can give rise to different kind of saccular disorders. Okay, so it can be air filled, it can be mucus filled, it can be purulent, তাই তো? মানে secondarily infected. If it is air filled, we call it laryngocyst. If it is mucus filled, it's saccular cyst. If it is air, it is laryngopyocyst. Okay, if there is pus. So considering the anatomical location, it can be anterior saccular cyst, it can be lateral saccular cyst, or the internal laryngocyst. Okay, or it can be lateral saccular cyst, internal or external, both it can be. Okay, so this is the saccular cyst. দেখতেই পাচ্ছিস একটা সিস্টের মতো জিনিস যেটা ইন্টারনালি বেরিয়ে আসছে, ইট ইজ এ ইন্টারনাল স্যাকুলার সিস্ট। ওকে, লোকেশন ইজ মোস্টলি অ্যান্টিরিয়ার, তাই তো? এর পেছন দিকটা পোস্টেরিয়ার, তাই তো? পোস্টেরিয়ারটা বেশি খোলে বড় করে, তাই তো? সো দিস ইজ দ্য the saccular cyst anteriorly located internal. Okay, this is the vocal cord, right? This is the false vocal cord, right? In between this space is laryngeal ventricle. So ventricle থেকে arise করছে। anatomy না জানলে একটু পড়ে নেবি, ঠিক আছে? I hope anatomy class হয়ে গেছে। Okay, so laryngocyst patient একটা external swelling নিয়ে প্রেজেন্ট করতে পারে, তাই তো? যখন তুই এটাকে প্রেস করবি তখন একটা গার্গলিং সাউন্ড আসে অনেক সময়, বুঝতে পেরেছিস? হ্যাঁ, ইটস নট আ টিউমার, ইটস জাস্ট আ নন নিওপ্লাস্টিক থিং, রাইট? কাদের বেশি করে হয়? ট্রাম্পেট প্লেয়ার্স, গ্লাস ব্লোয়ার্স, ঠিক আছে? যারা ট্রাম্পেট বাজায়, হ্যাঁ, ল্যারিঞ্জিয়াল ভেন্ট্রিকলের উইকনেস যেটা রয়েছে সেখানে একটা এয়ার প্রেশার কাজ করে, সো সেই স্যাকুলটা বাইরের দিকে বেরিয়ে আসে। ওকে, ওয়েট লিফটার্স, ক্রনিক কনস্টিপেশন যাদের রয়েছে, বুঝতে পেরেছিস, তাদের হতে পারে। টাইপস আবারও বলছি, এক্সটার্নাল মোস্টলি বাইরের দিকে, ইন্টারনাল মোস্টলি ভেতরের দিকে, অ্যান্ড ইট ক্যান বি কম্বাইন্ড। Laryngocyst in X-ray. Okay, this question has been asked. Bryce sign. Okay, gargling and hissing sound when the neck mass is compressed. It is known as Bryce sign. Famous MCQ. খুব বড় হয়ে গেলে it can give rise to stridor event because endolaryngeal space is compromised, right? Okay. ওকে, সো ভালসালভা এক্সরে করার সময় পেশেন্টকে ভালসালভা করতে বলতে হবে, সো দ্যাট ইট বিকামস মোর প্রমিনেন্ট। তোমার যখন when you are suspecting laryngocele তোমার অর্ডারে লিখে দিতে হবে, ওকে, প্লিজ ডু দ্য এক্সরে while doing Valsalva, ওকে। আর কি সিটি এমআরআই তো বটেই, হ্যাঁ, থরো ল্যারিঙ্গোস্কোপিক এক্সামিনেশন, ওর নিচে যে জায়গাটা তুই দেখতে পাচ্ছিস না, হিডেন এরিয়া, ইউ হ্যাভ টু সি দ্যাট এরিয়া ভেরি কেয়ারফুলি, কোনো গ্রোথ বা অন্য কিছু রয়েছে কিনা, ওকে। হাউ ট্রিট ইট, ছোটখাটো হলে কিচ্ছু করতে হবে না, বড় ছোট হলে ইউ হ্যাভ টু এক্সারসাইজ ইট। যদি এক্সটার্নাল হয় তাহলে এক্সটার্নাল অ্যাপ্রোচে নেকে ইনসিশন দিয়ে যেতে হবে, যদি ইন্টারনালি হয় তাহলে মাইক্রো ল্যারিঙ্গোস্কোপিক সার্জারি আগেন, ঠিক আছে, আবার ঢুকতে হবে, ঢুকে তারপরে ইউ হ্যাভ টু এক্সারসাইজ ইট আউট। কত ইজি না, সব প্রশ্নের উত্তর একই হচ্ছে, হ্যাঁ, বাট দ্য থিং ইজ সো ডিফারেন্ট, তাই তো, এভরি অপারেশন ইজ ডিফারেন্ট, হ্যাঁ। কিটা লোকেশন, কি লোকেশন বুঝলাম না। ও, লোকেশনটা সেম বলে অপারেশনের নামও সেম, এটাই বলতে চাইছিস, ওকে। ওকে, সার্জিক্যাল টেকনিক অ্যাগেন অনেক রকম ইনস্ট্রুমেন্ট ইউজ হবে, এক গাদা ইনস্ট্রুমেন্টের ট্রলি নিয়ে বসতে হবে, যেখানে তোমার মাইক্রোস্কোপ থাকবে, এন্ডোস্কোপ থাকবে, লেজার থাকবে, হ্যাঁ, ডেব্রাইডার থাকবে, ঠিক আছে, কোবলেটার থাকবে, যা তোর দরকার সেগুলো তোমায় ইউজ করতে হবে, তাই তো। এবার পেশেন্টের এভরি মাইক্রোস্কোপ মাইক্রোল্যারিঞ্জিয়াল সার্জারিতে একটা ঝামেলা কি, এক তো হচ্ছে ইটস আ কমন স্পেস ফর অ্যানাস্থেসিয়া অ্যান্ড দ্য সার্জন, তাই তো, তাহলে ওখান দিয়ে একটা টিউব যাবে, টিউবটা দ্যাট উইল অকুপাই আ স্পেস দেয়ার, সো তোর কাজের জায়গা কম্প্রোমাইজড হলো, ফার্স্ট থিং। সেকেন্ড থিং হচ্ছে এয়ারওয়েতে যে কোনো কিছু করলে, হ্যান্ডলিং করলে দেয়ার উইল বি ইডিমা, তাই তো। সো ইফ দেয়ার ইজ ল্যারিঞ্জিয়াল ইডিমা, কি হবে পেশেন্টের, আবার হোর্সনেস অফ ভয়েস, দেয়ার আর মোর ইম্পর্টেন্ট থিংস দ্যান হোর্সনেস অফ ভয়েস, শ্বাস নিতে প্রবলেম হবে সহজ ভাষায়, তাই তো, তাই তো, দেয়ার উইল বি স্ট্রাইডার, ঠিক আছে, পেশেন্টের স্যাচুরেশন হু হু করে পড়ছে, হ্যাঁ, পেশেন্টের রেসপিরেটরি কম্প্রোমাইজ হচ্ছে, মানে রেসপিরেশন কম্প্রোমাইজ হচ্ছে, ওকে। তাহলে আর কি, থার্ড হচ্ছে ব্লিডিং, ব্লিডিং হবে তো, দ্যাট ব্লিডিং উইল গো ওয়্যার, দ্য লোয়ার এয়ারওয়ে, তাহলে ব্লাড অ্যাসপিরেট করবে, অ্যাসপিরেশন নিউমোনিয়া হবে, সেখান থেকে ইনফেকশন হবে, নিউমোনাইটিস হবে, এটসেট্রা এটসেট্রা, ওকে। সো ডেলিকেট থিং টু হ্যান্ডেল, ঠিক আছে, ওকে। সো আরো ডিটেলে যাচ্ছি না, মোরালেস দিস থিং, হ্যাঁ, marsupialization, what is marsupialization, you will just open it up and keep it open, right, marsupialization, so that কোন রকম ফ্লুইড বিল্ড আপ না হয়, ওকে। যখন আমরা অ্যাপ্রোচ করতে পারছি না, হ্যাঁ, তখন উই জাস্ট ওপেন ইট আপ, তাই তো, and keep the flaps like this so that it does not close again, okay, marsupialization হলো, এত ডিটেলে যাচ্ছি না, and the tumors, okay. So these are the non-malignant tumor, squamous papilloma subtype 6 and 11, আর squamous cell carcinoma কত কত, হ্যাঁ, 16-18, গুড, হ্যাঁ। সো squamous papilloma 6 and 11, squamous cell carcinoma 16 আর 18, তাই তো। আর what is this, RRP, রিকারেন্ট রেসপিরেটরি প্যাপিলোম্যাটোসিস, ঠিক আছে। এই প্যাপিলোমা ভাইরাসের একটা বাজে হ্যাবিট আছে, ওকে। হ্যাবিটটা কি, রিকারেন্স, বিকজ ইটস আ ভাইরাল থিং, রাইট। সো রিকারেন্স ইজ আ ব্যাড থিং, হ্যাঁ। আর এটা এমন ভাবে স্প্রেড আউট করে, ইফ ইউ ট্রাই টু ডু এনি ইনস্ট্রুমেন্টেশন, ইট ক্যান স্প্রেড আউট মোর, ওকে। সো ইউ হ্যাভ টু বি ভেরি কেয়ারফুল, হ্যাঁ। ওয়ান অফ দ্য কমন রিজন অফ চাইল্ডহুড স্ট্রাইডার ইজ দিস থিং, RRP, okay. JORP, juvenile onset respiratory papillomatosis, okay. Young mother, vaginal delivery, low maternal socioeconomic status, these are the susceptibility factors, because vagina is known for papilloma, right, especially 6 and 11. So during the birth, the papilloma virus can enter in the larynx. It's very aggressive, র্যাপিডলি রিকারেন্ট অ্যান্ড বারবার। আমার একটা পেশেন্ট ছিল ন্যাশনাল মেডিকেল কলেজে, শি হ্যাজ আন্ডারগন অ্যারাউন্ড 7 to 8 times of surgery to remove it. Every time she comes with some kind of stridor. Okay, so it's so notorious. Okay, that's why we came with some vaccinations. Right? Vaccination is very important. Okay, so adult papilloma, these are less aggressive, but behavior is more or less same. Okay. Okay. Single removal leads to cure sometimes. Okay, but it can be recurrent as well. This is a typical look. Sometimes confuses with growth, right? But বয়স, aggravating factor, risk factor সব কিছু অ্যাসেস করে আমরা এটা respiratory papillomatosis ইয়ে করি, হ্যাঁ। So in respiratory papillomatosis we try to avoid tracheostomy. Okay, we try to avoid tracheostomy because with tracheostomy it can spread more, right? Okay, so if you are in confusion, obviously if the patient is having some severe symptoms and stridor and all, and in confusion we will remove it out, right? We'll take a biopsy. These are not required for you. Interferons are extremely important. Acyclovir, ribavirin, cidofovir, all these things. Okay, antivirals. And surgically we always use lasers. Okay, with lasers we try to avoid it, try to excise it. And adjuvant therapies, vaccine therapy, gene therapy, these are all experimental. Okay, cidofovir is extremely important. It's having, especially in bulky lesions, along with surgery, we recommend cidofovir. Okay. Okay, complicated thing, not for you. Rhabdomyoma, muscle origin. The malignant one is rhabdomyosarcoma, extremely aggressive. Myoma is benign. So local excision is important. If you get a lesion that is favoring that it can originate from a muscle level, we will excise it out and we will get a biopsy. Adipose origin lipoma, it's an universal tumor. It can happen in anywhere in your body, right? Lipoma can be there. Glandular origin, pleomorphic adenoma, most commonly in salivary gland, because there are minor salivary glands, you can have pleomorphic adenoma. Again, excision is the mainstay of tumor. Oncocytic neoplasms, again, excision is the mainstay of tumor. Okay. Cartilaginous neoplasms are extremely common. Chondroma, we get it frequently rather than all this lipoma and all. Okay. Chondroma means arising from cartilage. So larynx has cartilages, right? Paired, unpaired cartilages. It can arise from cartilages. Again, excision is the tumor. Excision is the treatment. And vascular neoplasms, it can be anything, any hemangioma, any malformation, any granulation, anything. Okay. Polypoidal granulation tissue, I have already told you. Capillary hemangioma can be there. Okay, polypoidal granulation tissue, one of the several factors of trauma, blah 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 blah. More or less, vascular tumors can be there. Okay. So how will you treat it? Ablation. Okay. ছোটখাটো হলে ablation. Ablation করতে গিয়ে ব্লিডিং হতে পারে। লেজার দিয়ে করলে কি আর ব্লিডিং হবে না? It depending upon the extent of the tumor. Okay. Sometimes ablation is okay. Sometimes complete excision. Okay. তাই তো? Sometimes doing nothing is also okay. Okay. ছোটখাটো একটা হিমানজিওমা রয়েছে, কোনো রকম সিমটম নেই। কি হিমানজিওমার সিমটম কি হতে পারে? ল্যারিংসে মাঝে মাঝে ব্লিডিং হতে পারে, হিমোপ্টাইসিস, তাই তো? বড় হয়ে গেলে কম্প্রেসিভ অবস্ট্রাকটিভ সিমটমস হতে পারে, তাই তো? এবার ধর সেরকম একটা আছে, কিছুই করছে না বেচারা, বিনাইন একটা লোক বসে আছে, ইউ নিড নট টু ডু এনিথিং। ওকে, পেশেন্টের যদি স্ট্রাইডার হয়, ইউ ক্যান ডু মেনি থিংস, রাইট? মোর অর লেস এক্সিশন ইজ দ্য ট্রিটমেন্ট। ওকে, সো হিমানজিওমা ল্যারিংস, হ্যাঁ এখানে একটা ওই আমাদের বিটা ব্লকার প্রোপ্রানলের রোল আছে, ওকে, স্পেশালি পেডিয়াট্রিক হিমানজিওমা sometimes we give beta blockers, that regresses the tumor size, okay. Neural origin, granular cell neoplasm, you can have schwannoma as well, ঠিক আছে। all these things যতগুলো ওমা রয়েছে পৃথিবীতে সবকিছু হতে পারে, ওকে। নিউরাল অরিজিনে নিউরোফাইব্রোমা হতে পারে, নিউরোফাইব্রোমা জেনেটিক্স জিজ্ঞেস করবে, টাইপ কি কি টাইপের হয়, NF2, কোনটা কোন ক্রোমোজোম, তাহলে আর কি জানবি, NF1 NF2 এভরিবডি নোজ। NF1 NF2 এর সাথে ইয়ার এর কোন সম্পর্ক আছে? আচ্ছা দেখে নিবি। NF1 NF2 এর সাথে ভুল বলেছিস, NF1 NF2 এর সাথে ইয়ার এর কোন টিউমারের সম্পর্ক আছে? ইয়ার রিলেটেড acoustic neuroma, bilateral acoustic neuroma, it is found in NF2, right? So neural amimoma, all these things. So any confusion? No confusion? তাহলে ভালো করে শুনিসনি। Any confusion? Anybody? Take home message. Every patient will have hoarseness of voice. Every patient can sometimes be dyspnea. It has to be, first thing, aggravating factor, you have to identify it. You have to thoroughly examine it, right? With laryngoscopes, fiber optic, rigid, all kind of laryngoscopes. Then you have to, first medical management will try to control the GERD, ask the patient not to abuse the voice, smoking বন্ধ করো, অ্যালকোহল বন্ধ করো, লাইফস্টাইল চেঞ্জ করো, all these things. তারপর medical management fails, then microlaryngeal surgery তে আমরা কি কি টুলস ইউজ করি? ডেব্রাইডার প্রথমে বললে হবে না, কোল্ড স্টিল ইনস্ট্রুমেন্ট, CO2 লেজার, তাই তো, ডেব্রাইডার, কোবলাইডার, all these things, as simple as that. বাট ততটাই ডিফিকাল্ট হচ্ছে কার্সিনোমা ল্যারিংস, ওকে।